Glad to see this overwhelming turnout. But that's all right. Maybe we'll get more talked about this way. Hi, Ken. Hey, where do you go? Well, Murray Solomon, who has masterminded this week, has said that we're going to talk about why do people have to wait 2 hours for in student health service, which isn't a bad place to begin. And to vastly oversimplify the matter, but dramatize it, I think the underlying reason is that there are perhaps only 65 to 75% of the staff needed to take care of the expectable needs of a student body of 30,000 students. There are just too few people, rooms, resources to handle the demand and expectable load. So even though the existing staff is truly busy, and anybody who has worked there or even sat around waiting knows that the staff aren't by and large knitting or holding long raps with each other. And even though we see somewhere between 600 and 800 total student visits a day, which is an awful lot of patients, and incidentally, when I tell that to anybody in the medical school, they go white. You know, almost any talk that has existed about, well, maybe the medical school should take this over, this kind of thing. You say, okay, you're ready to handle that kind of visits, and it boggles them. They deal largely in more consultative types of complicated cases, and a clinic load of maybe 100 is a big load. So there are just too few of us trying to serve too many of you. And anytime you have this situation, you are bound to have some delays. You're bound to have individual patient contact by the time you get to see the health professional. You're bound to have it be shorter and perhaps more impersonal or less personal than it would be if more time were available for each person. Now, okay, up until a few years ago, I think the situation was even perhaps worse than it is now. In those times, not too long ago, as recently as 1969-70, the service was pretty well philosophically organized along the, quotes, traditional doctor's office line, in which the nurse and the attendant were basically merely attendants or handmaidens or companions of some kind, and performing certain tasks if ordered, but every patient was required to see the doctor. Now, any of you know that if you've stuck a splinter badly into your finger, you can't get it out, and maybe it looks a little bit red, but not really too bad. You want to get it out, and to go in and wait for 2 hours and finally get to see a physician who either pulls it out rapidly or implies that, well, this is a silly thing to waste time on, and so forth, that this is an absolutely infuriating thing. Or that the person who has a mild sore throat, they're not all that sick, but they've got exams coming up, they've got papers coming up, they've got obligations and things scheduled, and they damn well don't want it to get worse, and would like somebody to cast a judicious and preventive eye on it, again is not too happy at having to wait 2 hours only to spend 2 or 3 minutes with the doctor. So about 2 years ago, an internal change was made And this I use simply to illustrate some of the kinds of changes you can make within an existing staff to serve people better. And this was essentially the upgrading and retraining of nurses, of some of the nurses, to do more than they had been allowed to do before, and that is to exercise some independent clinical judgment. Now, I don't believe, in fact, I'm pretty sure from experience around the country, that most students, provided they feel the attention they get is fairly prompt, fairly efficient, and seems appropriate to what their expectations were, they don't really care much who gives it. In other words, if the nurse reacts confidently and appropriately and renders the kind of judgment or decision or opinion or treatment that the student expects, in 99 out of 100 cases, students are quite satisfied with that. They do not usually insist, well, you're just a nurse, I've got to see the doctor, particularly if this has been handled, as I say, fairly promptly and well. I'd be interested in any counter reactions to that or people, but this is certainly my impression. By training 8 nurses and assigning 2 of them in rotation at all times with one doctor to the so-called primary clinic, I think we have saved many students with relatively uncomplicated or relatively minor things, saved them the extra hassle of having to wait and fight their way through on a routine basis to the doctor. And those nurses are now seeing about 30% of all the clinic load without having to go to the doctor. This saves the doctor's time for the more complicated or the more obscure kinds of cases. Now, this is one example of an internal program change where you say we're going to have different people, we're going to spread this work around among different people, and we're going to use paraprofessionals wherever we can. Now, this has helped, and further moves in this direction will be, I think, still further helpful when we can do them. Now, another kind of internal change that may loosen things up, may speed things up, and may make the kinds of service that most students need most of the time more readily available, will be somehow to shift the emphasis now placed on the so-called specialty clinics. Not that they're not needed, or not that such functions aren't needed. When you need a hematologist, you need a hematologist. When if you've got something definitely wrong with your thyroid and it's complicated at all, then you do need to have access to a competent specialist. I think one of my serious questions is whether the present way of doing it, that is, of the use of a large amount of space, a large amount of nursing time, and essentially one whole side of the health service, whether its use for this kind of purpose is really as effective as it would be perhaps to make an arrangement for some of the clinics with, say, a medical school department or a practice group within the school, and simply refer those patients there, thus loosening up some of the nursing time, some of the space to provide more general and direct kinds of services. These are the kinds of maneuvers that, without a lot of budget change or a lot of personnel additions, can somewhat ameliorate or somewhat improve the problem. And as I say, I come back to the point that probably 80% of all the visits of students to a student health service in a year are not for the fancy or the specialized or the highly esoteric things. They're for the ordinary things that bother most of us. And it's there that the bottleneck comes, and there that the major problem comes. So I think we can achieve some strengthening of general clinic, primary clinic, as against the, and still provide specialty services by referral or other mechanisms to those who really need them. Right now, a lot of the specialists are really handling overflow, if you will, from the general clinic. In other words, many of them will say, well, about half the cases or a third of the cases I see really would not need to be referred to me if there were time for a good general physician to take care of them. And of course, now, the way the appointment system, the way the time slots work, if you're going to overflow in that way, you usually have to make another appointment, another visit, and this doubles your total trippage back and forth. Whereas perhaps if there were more generalists, more time for them, some of those visits could be saved, which is a saving of time and money to you. Now, even if these things are done, I think the improvements will be probably visible to those who frequent the place and who and to quite a few individual students. But I would guess that still there will be waits, and in other words, you can't cure the whole situation that way. All right, where do you get more money? Or for more staff, for expansion. We can maybe make space, we can maybe save some nursing time, so we can call that money, if you will. What about the hospital situation? Now, here, even though we are paying for an inadequate amount of hospital time, 3 days, when I say inadequate, the average hospital stay, as you may or may not know, is closer to 4.5 days or 5 days. We subsidize 3 and then cross our fingers, if you will, hoping that the student has either some insurance that his family or his employer has held for him, or that he has bought the supplemental UCLA insurance. And if he hasn't, he is theoretically on his own and out in the cold. In practice, what happens at that point is that everybody agonizes, and there's a lot of running up and down stairs, and generally we wind up paying it anyway. We had a recent case of a student who required major surgery, was in the hospital 8 days, no insurance, no coverage, no dough, foreign student, and morally, we really had no choice but to extend the coverage beyond the 3 days in that case. And this happens often enough to pose a problem. So while we're subsidizing an inadequate number of days, it still costs us a lot of money to serve these complicated needs for a relative minority of students. Roughly 300 between 300 and 400 students per year are admitted to hospital, and that is that's per year, and that works out to be about 1% of the student population, whereas probably 90,000 student visits are made to the Student Health Center a year. So there is what I mean when I say we're paying a lot of money to pay for the complicated needs of a 1%. These 400 odd admissions and the 3 hospital days work out to something in the order of $200,000 a year. Now, with $200,000 put in another use, one can buy a good deal of good general physician help, good nurse help, and so forth. Meanwhile, what to do about hospitalization? How do we cover that? Can we say because it's only 1% of students get admitted a year that we'll forget it, that we're not going to do anything? I don't think we can do that. People just won't put up with it. The results are, the penalties for having no provisions at all are too serious, too severe. A person might get away with nursing their own cold or their own sore throat, but with an appendix or with a bad pneumonia or with a fractured femur, they have no choice. They need the care. Now, a lot of people have existing hospital insurance, either through their families, maybe one or both parents are employed and have a insurance plan which includes a student dependent. Many students work in addition to being students, and through their employers have some kind of hospital insurance. Yes?
Excuse me, I came in late. Will you be taking questions?
Oh, yeah, right. I'm just trying to lay the groundwork, yeah. I don't have a figure as to what percent accurately of the student body is already so covered, but the guesstimate is that maybe 70% are so covered. An additional 15 to 20% purchase the UCLA supplemental insurance. This leaves uninsured maybe 10 to 15%, something in that order. And it's remarkable with the frequency with which it's this group that has the serious auto accident or the serious illness. Now, our support comes largely at this point from the reg fee, as you probably know. Reg fee is at present the only officially recognized way of taxing all students for student activities that should be available to all students. And years and years ago, when medicine and healthcare were a lot less complicated and a lot less expensive, an acceptable degree of service was able to be fitted within that framework. But now, still stuck, if you will, are still pretty well determined in our size and scope by the reg fee concept. That fee is simply no longer able to purchase in total the kinds of services that we think students should have and that students think they should have. And I don't really, frankly, see much chance of this radically changing as long as the reg fee remains the sole proprietor or arbiter for student health services. I think obviously it's got a necessary and important contribution. But aside from adjustment of maybe $25 roughly per student per quarter now from reg fee goes to health service. That $25 per student per quarter, as I say, is no longer able to buy adequate hospitalization, fails by about 25 to 30% of meeting the common ambulatory or health service needs of the majority of students. And maybe you can expand it or change it by $3 or $4 per student. I would even have my doubts about that when one has to compete with all of the other things that are funded by the reg fee. So I think what I'm saying, I don't know all the precise answers to this, but as I look down the road ahead, that if what is wanted and what is needed, as I believe, is a more appropriate, more adequate service, both in terms of quality and in quantity, with some guarantee of adequate protection against the major hospital loss, then I think we're going to have to look to some kind of mechanism through which those students who are not insured against hospitalization will be required or assisted or both in obtaining hospital insurance, and that some regular fund again, presumably from students, but as time goes on, maybe increasingly helped by government. In other words, it's student money, but the money may come to them through the government, either such as Medi-Cal or federal programs. But some money over and above the reg fee allocation, or we're going to remain not only where we are, but because things get more expensive and expectations increase, we'll probably functionally go backwards. Now, with that for background, why don't we have some questions?
No, I was just wondering, like I was into the dental services 2 days ago, and this dentist there said that they were losing $1,000 a month, and he was only donating his services to appease the students, and that service is only was on an emergency type basis. And he was like telling me that, what was I doing there if I wasn't in an emergency case? So he was preaching to me that I shouldn't even be there at all.
Well, again, I think this is a vivid example of the squeeze you get into between too little for too many. To say you can really offer a dental service that affects or reaches majority needs with 4 or 5 part-time dentists and 4 or 5, no way you're going to do that. And so what you have to do is to say, all right, we will treat only a certain kind of case or a certain kind of person. We'll do a means test and only take the needy or this kind of thing. Now, because
the question is, what are the responsibilities of that dental care service? I don't know. In other words, the guy that
they are supposed to be for emergency care available to any student. And additional care, restorative work, on the basis of apparent student need, financial and dental, on a catch-as-can basis. In other words, it's to some degree who gets there fastest with the mostest and fills up the time and pays for it. The subsidized portion of the program really only supports one part-time director and the administrative assistant who sort of sees that the whole thing goes. And the rest of the staff are supposed to be self-supporting on the basis of the fees. In other words, that's a little sidelight. The income disappears somewhere, or the more income we make, then the less reg fee gives us, because they say, well, you're making this money, so you don't need so much from us. But meanwhile, the students get asked to pay more separate fees, and I'm not sure this is what they want.
Like this guy, all he did was, he looked in my mouth without washing his hands, and he said, well, that'll be $3, and he didn't do anything else. So I'm just questioning, $3, I don't know what for, So, and then, his attitude was very, like he was patronizing me for his services. So I was...
Well, he probably figured that $3 was little enough to pay for an exam. He probably would have charged $25 in his own office. He says, so you probably say, what are you complaining about, huh? What are you complaining about? Well, I know what you're complaining about, and as I say, I think the answer is that here's a handful of dental people implying that they're going to offer any student some kind of service, which they can't do, so they have to restrict. And they begin to restrict on basis of judgment about how needy you are or how needy you're not. And if he doesn't figure you're too needy, looks in there, this guy doesn't really, he's not in tough shape. So what do you come in here for? We got things to, we're too busy. We can't be bothered with you. It's wrong, but that's the reason.
So the majority of emergency cases and treats get treated hand and foot, which is all right, as long as it extends to the nationals too.
Yeah, right, right.
But that he was really bragging about that. Like, well, here he treated 3 foreign students and did a complete whatever he did. And, but I mean, he was really proud of that.
And your feeling is that he should be equally proud of rendering.
No, my feeling is that like he was preaching to me like he was my father and I was his son. Like he said, well, for your information, bright boy, that's what he said. Some big tall dude,
Big tall dude, yeah.
With white hair. What? Another question I'd like to ask you is, how much in-kind service are you applying for? Do you have any?
How much what?
In-kind service. Do you have any?
In-kind service? I'm not sure what you mean.
Well, I mean, volunteer support to the student health services.
I mean voluntary financial support or
Like from the professionals there at the hospital.
Oh, for the professionals within the hospital? All right. At the present time, virtually, if a student patient has a major surgical operation, appendectomy, or use that as an example, it is costing perhaps $20. The reason being that the surgeon is accepting a fixed and relatively low retainer, regardless of how many patients he sees, regardless of how many operations he does. Now, if he goes through a month with no operations, he can be said to be making a below average, well below average fee for being on call and seeing some scheduled patients. If he does one, he's already virtually giving the operation for nothing, and if he does 4 or 5, the price comes down, I figured, to where you're getting about a $5 appendectomy. Most of the consultants, specialty consultants, are giving their service on a retainer basis for considerably less than they would be making for spending equal time anywhere else. If you don't offer them anything, you don't get them. If you go on a straight referral basis, we will refer them all out. Then you run into a situation where the doctor says, well, I don't mind giving this service, but if I give it, then the department cannot afford to keep going because our hospital rent costs and so forth are too great. I think it's kind of unrealistic to expect large numbers of doctors to reliably be on hand and spend adequate time with any patient referred to them on a totally gratis basis. It just, the medical school doctors take care, supposedly, of the medical students at no professional charge. But they don't keep records either, and there's no continuity. It's not very good care. Yeah.
Are there certain procedures in hospitals where the attending physicians rotate through outpatient and clinic departments? Does this happen here in UCLA?
Yeah.
Now, why couldn't they be incorporated routinely to rotate through the student health service as part of, say, do they do this on a month, basis? There's some kind of rotating schedule that's set up on this, I assume. So could not the student health service be incorporated in this?
Well, in a sense it is. In other words, that many of our consultants are people from the faculty who rotate through. But in turn for that, that's an extra rotation. It's not, if you will, originally part of their paid duties. And in general, somebody has to pay for it. Now, as I say, I think we pay probably less than a lot of places would. I now, for instance, in the Department of Obstetrics and Gynecology, I have paid them a really ridiculously small amount of money in return for their assurance that they will provide 4 hours of a gynecologist's time to us a week, which is about 4 hours we don't have scheduled. That's 4 months ago, and they can't find anybody in the department to do it. They're all busy with what they thought they came there originally to do. So I think what I'm saying is that to depend on free service on the medical school doctors because they're there is unrealistic. It doesn't work out. And I think also to spend large amounts of money out of the basic reg fee for some of this is also beside the point. I would hope that more of that would be covered by insurance that would be held independently of the reg fee. Yeah.
Yeah, another question. As far as the priorities of the health service, I would assume that the bulk of students coming in would have a set amount of problems, either upper respiratory infections or either venereal disease. I don't know what the statistics are. And I would also assume with the priorities that some kind of preventative or health educational approach would have been attempted. And I didn't see any in view when I went through. Is there anything being done in this area?
I think much is intended in this next year's budget. I'm requesting for a full-time health educator to help the staff know what to do. You know, a lot of talk's getting about health education, and what it really amounts to, or how it is most effective, is still kind of a moot point. It's like saying, "Oh, let's do more preventive medicine," but you know, when you try to nail down an expert on exactly, okay, what effective preventive programs can you show me? It's awfully hard to say, here it is, and we're going to substitute this program for what we're doing now. One of the few you can point to is a conception counseling function. If good conception counseling and prescription and clinical service were freely available to all students, I'm sure that although it would cost something, it would cost them and other people less than the 18 abortions a month that we refer out. You know, there you can say, if you do this, you are going to get a trade-off. It's an awful lot harder to say exactly how much health education is going to, if you will, prevent this or help that. A good health education program might result in greatly increased use. See, in other words, all I'm saying, I'm not against health education, I'm all for it, but I think the assumption that you're going to substitute that for something else and save money or whatnot has to be very carefully thought through.
Yeah, well, I raise this point because I feel it would probably, I'm not sure about the volume coming in, whether it increase or decrease. I hadn't thought of that point, but I think on the whole it would increase the quality of what goes on there. I've seen people go through. I've only been there once.
I agree with you. Yeah.
From there as much as possible. You know, I'm not a frequenter. But in my experience going through, the education that went on was absolutely nil. And if I was a younger person, or if I was uninformed about certain problems in my particular case, I would have been at a loss. It was appalling.
Yeah, no, I agree with you, and I think again this comes back to the function of I'll call it the panting syndrome, but I mean it's you know, you got to hurry on to the next case because we got so many right. Okay, well there isn't, you know, the opportunity then for the kinds of dialogue, which I think are the most important parts of health education, is what goes on between a person, a patient, any patient, who is there because they've got a concern or a question or a problem, and the person that they're talking with. I think this is crucial and very central. To me, that is what health education really is, as opposed to, a little program of slides or brushing the teeth and so forth. But no, I'm interested in priorities, because this is really what we're going to have to do, is we're going to have to decide what are the most important things and go for those, and downgrade or shift responsibility for some other lower priority things to other financial and other service areas. And this is something I need to know. A couple other people have some questions here.
Has there been anything done with the medical students? I mean, have they participated, or have they been incorporated at all? Because that could be part of the training.
Have the medical students been incorporated in the program as participants? Not yet. I don't think they're ready, and I don't think we're ready. But
some things such as counseling and things like that, they are ready after a few years of training.
well, I think they may be clinically ready. I don't think there's any. This is going to take time in terms of getting the school and their curriculum people and whatnot to say, yeah, this is an important part of their training, so we've got to liberate up time for them to do this, if even on an elective basis, and we've got to be prepared to have the time to supervise them. You can't just, I don't think you can take any trainee and just say, go and work a shift, unsupervised and so forth. I'm all for it, and for the use and training of various health professionals to a greater degree than we have now. It's going to take a little time.
Yeah, I'm not really worried. I don't get to see health service very much, and I'm not really worried about dialogue, with the doctor or anything. When I go there, I want good, competent health care, okay? And I don't know, I had a problem once, and I'm really kind of scared to go to the health service anymore. I went in once, it was just a minor thing, but it was worrying me, and my ankles were hurting. The guy goes in and he takes a blood test and he goes, you've got gout, just on the basis of a blood test, just like that, And never took any other tests, never did anything else. He just took over a period of a few weeks, about 10 different blood tests. And then he told me, well, there were 2 drugs you could use for this, one was probenecid and another was allopurinol. And he says, probenecid's cheaper, so we'll use that. So anyway, I was really, he was feeding me all these drugs and everything, and it wasn't really doing much good. So finally I started talking to someone where I worked, and they said, well, you can't diagnose gout on the basis of blood testing. It can't be done. So finally I had to go to an endocrinologist. It cost me $150, and he took a few tests, and he said, this was after taking drugs for about 2.5 months, and he says, no, you don't have anything. You don't have gout. He said you may have something else, but unless it flares up, we can't tell. But you definitely don't have gout.
What else did he do? I'd just be interested, the endocrinologist.
Well, the endocrinologist took an acid-rate, urinalysis, a blood test, and a couple other different tests. But he took a bunch of tests. And he X-rayed my feet, and that was it. And he said, you don't have it. But I was really surprised. I would have been much happier if they would have told me originally at the health service, well, look, I don't really know about this. Maybe you better see an outside specialist on your own money.
Did you see one of the endocrinologists?
No, he just said, this guy just said, I got worried about it. And they all said, well, he's competent. He knows what he's doing. He's the student health service doctor, and he knows what's going on. And they said, no, we can't really.
Was it in general clinic, or did you make an appointment?
Well, after the first time, I made an appointment. It was Rothrock.
Mm-hmm.
The guy.
Mm-hmm.
I was back there like 5 times, and they take a blood test a week or a couple times, and they had me each on diets and all kinds of stuff. I never had nothing. And what if it was something, I don't know what those drugs can do to you. I don't really know too much about it. It really kind of burned me up though, and I've really been hesitant to go there ever since.
Well, is no sense in my fighting this because, okay, you know, it happened, and I'll say this, it's going to happen no matter where you are. At some time, maybe not to you, but somebody's. I mean, I don't care where it is. There, you can find a tale of poor treatment or misdiagnosis and so forth.
Yeah, I just wish though he would have told me, you know, I don't feel confident in treating this, you know, go somewhere else. That would have been fine with me. I had to do it anyway, and I could have, you know, saved myself 2 months of worry and, you know, a whole bunch of money for drugs. And also the approach, I thought the approach was downright shiftless to, you know, tell you know, well, this drug is cheaper, you know, we'll use this one. And I was later told by someone that that definitely was not a good drug. In some cases could be harmful. And he said they would have had no way of knowing how it would be with you without taking further tests. So, you know, if they just tell me.
Well, I don't know what the facts are. I don't know. You still may have gout, you may not. I don't know. You believed one guy, you don't believe the other. The important thing is that whether you're right or wrong, you certainly felt you didn't get treated right. And you may not have. Again, I think when we can get enough people and pay them enough, you know, to guarantee the quality, we're going to be, this is going to happen a lot less often. Can I just follow through one thing? You know, you hear suggestions, well, why not junk the whole thing and simply use the money to buy an insurance policy so you could go see your endocrinologist and so forth. You could, reg fee, if you use the whole thing, if you use the entire reg fee, it's doubtful whether or not you could, you know, buy the kind of insurance that's going to enable you to go when you want and get that kind of work done.
Well, it's just like I wrote to the doctor, and I do the best I can to stay away from doctors, you know, something like this is really.
Yeah, there's some people who are never going to come in at all and who say, well, gee, I'm always healthy, I never get sick. So why should I, you know, I don't need a health service, I don't need a doctor, so why should I pay? I think that goes right back to saying, all right, we'll leave it up to each individual to pay for what he needs. And this means he's going to pay nothing, and some guy's going to pay $10,000.
If you're getting treatment or you don't feel you're getting a certain treatment, what avenues do you have in the health service to do anything about it? Who can you know, can you say to someone, you know, I tried to say.
You sure can. You don't have to go see a given person each time.
I told them I wanted to see another doctor, and they said, well, he's the one that treats those kind of cases, and he knows what he's doing. And they said, you know, we really can't do that. You know, I'm like.
Who said that?
I called over the phone. It was one of the nurses said, you know, we can't do that.
Well, that's not true. In other words, they may have said this, but it shouldn't be true. I mean, anybody should be able to say, for whatever reason, I don't trust the guy, I don't like him, I don't think I'm getting the right thing, let me see somebody else. I mean, this is any patient's privilege, you know.
That dentist told me the same.
Saying what?
That what this gentleman back here said.
What do you mean?
That I couldn't see anybody else.
Except him? Well, that's wrong. That is just plain wrong. Because I don't know any, you know.
That's what's going on. Maybe you can't see it in your wherever you work at, but that's what's happening. You know.
If I could have seen an endocrinologist within the school and knew I could have, you know, I mean, like, I'd rather see an endocrinologist that knows what he's doing at UCLA than pay $150 an hour.
We have two of them that spend a total of 4 hours in student health a week, who are on the faculty, you know. Well, that's wrong. You know, that's bad. Now, those are the kinds of things I think we can fix because
Should try.
because that is just plain wrong and should not go on. Any patient has the right to say, I'm not, you know, it is stupid to go to see somebody that you don't have confidence in yourself. He's not going to do you any good. He can be the most competent guy in the world, but if you don't believe it or whatnot, it's a bum scene, you know. But You know, these kinds of things, I think, can definitely be fixed. And
One question
I got a question. You alluded earlier to the fact that if you could pay doctors here enough, that the quality of service would be improved. First of all, I would like to know, what is the salary of staff doctors in the student health service?
the salary is a range. In other words, from a low, 5 steps. But for a physician without specialty credentials, in other words, a GP type physician, and this doesn't, knock him because he can still be a good doctor for many things. That starts at about $23,500 and goes to a top of I think it's $27.7 thousand annually gross. With specialty certification, he would start somewhere around 25.5, with a ceiling of around 30. Now that sounds like a lot of money, but for essentially, a full-time, say, professor of medicine in the school here would be grossing somewhere closer to 40, and we can't get a lot of competent people to come in at those salary levels because they say, hell, I can make 10,000 more than that starting out at IBM or the phone company or industry or in private practice. So these rates are up somewhat from last year, and I think they will help us. But they do restrict your ability to go out and pick out a guy because you want him and say, here, you don't have much bargaining room.
I was just wondering because I didn't feel that quality care was necessarily hinged upon how much a doctor was making in this type of
It doesn't necessarily. In other words,
coming up.
well, it does. What it reduces to some degree your chances, or the bag out of which you can recruit, or out of which you get applicants. And you're more apt to get the retired or retiring person or the ex-military person, and who, very frankly, are maybe looking for something with a few less hours and a few less responsibilities, as opposed to somebody who really wants to take care of patients because he likes it and is good at it. Now, I don't say that we've got, I think, some excellent physicians there who are working at that kind of wage, but it just, your chances would be better, I think, if you could pay more.
But what I'm getting at is that we're paying so-called doctors salaries, and we're not able to recruit competent doctors. Many people feel are competent doctors. So in the end, we're paying again because we're going to have to go outside and see a specialist or someone who we feel is much more competent, or some of these doctors who hold part-time staff positions, and you have to go out and see them on their office hours because they won't perform the type of things that you need here at the Student Health Service.
Such as
The allergy clinic, which is not here anymore. How many people at this school have allergy-related problems? And the school cut out the allergy clinic.
We're putting it back.
Yeah, but what happened to the people in between? See, we run into these.
I'm not going to take any responsibility for what went on before.
No, I'm not. Well, I'm not saying you should take responsibility for what went on. What I'm saying is these are some of the gripes that a lot of students have. We're paying. We have this feeling that we're paying for what should be quality care. We're not getting it, so we have to pay double because we have to then go out and pay on the outside market for care that we
Well, if you feel you pay double now, maybe by paying about 25% or 30% more, we could get the quality. Yeah, as I say, a hell of a lot of it is just a matter of volume, and the fact that the program is determined not by what's right and what's good, but by saying, here's a certain amount of money, live within it. You know, there's no way you're going to do it.
So why don't they just get down to the nitty-gritty and raise the fees then? I mean, if that's what it takes to get good health care, it seems.
Right on, man.
That
Yeah.
seems your only answer.
I mean, the fee for service, like, which fees are you talking?
Say, okay, suppose raise the reg fees
Mhm,
$10,
mhm.
you know, give them a third more if that's what they need.
Well, this is what I think is going to have to happen, and I don't think it'll be within the reg fee, because to do that, you have to raise it for the entire system, all at once, you know, for all 8 campuses, and the regents are the ones who say yes or no. And,
I mean, I'd juggle the allocations of the reg fees. Instead of spending so much money on intercollegiate sports, spend more money on health.
I'm all for it.
But how much pressure does the health center put on this allocation?
I don't think they've put a lot of pressure on before, and if you want to look at it one way, one reason I'm here is because I want to start putting pressure.
Why can't they divvy up the full-time salary pay that they do a specialist and support some of the medical students that are in med school? In other words, pay them a stipend, you know, maybe 5 times, and that would enhance more 3rd, 4th year medical students to help, you know, and being paid for it, you know, rather than hire one guy full-time for 2 days a week. You could pay, you know, salary 5 times and help a medical student, and I'm sure he's just as competent and probably more competent than these guys retiring from the Air Force and whatever else.
Well, in other words, by buying a younger, cheaper
Not cheaper, I'm just saying helping.
medical body, you could get more of them and so forth. I don't, for a number of reasons, think that's going to work.
Yeah, but you're sitting up here being very negative. You haven't tested any of these so-called things you think they're not going to work. So you don't have any basis by which to make that statement,
You know, I kind of think that maybe health care be degraded, but I don't, the thing that I
It's
don't
bad
see is,
now.
you know, like, I would rather pay $35, you know, $10 extra on my reg fee for good care than $25 for garbage care, because $25 for garbage care is $25 wasted.
For 30,000 students, do you think an extra $10, how much would that be? $30,000?
That's a third more if they get the 25.
No, you're talking about $10 a student for 30,000. That's on a year. That'd be 300,000. You know, roughly $300,000. And that's about the kind of dough we're talking about.
Would that ameliorate some of the problems?
I think it would. We'd still be somewhat restricted by the fact that even if we got more money for more competent and better doctors and nurses and so forth, we're going to have a problem of where to put them until we get a new building. And this is why we're planning a new building.
What about the use of paraprofessionals? I heard you.
Oh, well, we're into that to a limited degree. We'd like to go into it much more. Again, simply to make the skills that are the more routine or less complicated kind available to more people, you know, by allowing better use of the paraprofessionals.
Well, here, this gentleman presented an idea of dividing up a full-time staff salary between so many medical students who you would think are much more qualified maybe than paraprofessionals, people who can handle routine duties. These men could handle routine duties with a little more specialty, a little more knowledge than paraprofessionals with.
You ever watched him?
The program is
Listen, I've just come off of 5 years of working in special health service in a medical school. In other words, medical and dental students only, and nursing students. And I know 4th year medical students and 3rd year medical students.
But these are the same dudes that are going out and getting their license to say, well, if they're no good in medical school,
Not until after they've been through an internship and usually 2 or 3 years of residency, they're not.
A lot of schools are cutting that out.
Sure.
Cutting what out?
Internships.
Internships and residency things. A lot of your medical
Stanford
schools,
University Medical School.
Has done what?
they've reduced their
No required
3 year
classes.
down to 3 years.
Yeah, it's still
Reduced what down to 3 years? The medical
The
curriculum?
time that they have to spend in medical school and internship, and I don't know the formalities, they could reduce the thing by 1 year. John Hopkins,
Well, Stanford used to be a 5-year school before you got the MD, and then you had an internship, so they may have gotten it back down to 4 years now, which is...
you're being very negative. And not-
Well, the thing is, I just have profound skepticisms because of you say I have no experience. Well, hell, man, I do have experience. And I would...
Your experience to come up with any solutions, you know? Your only solution is more money, you know? And,
No, I've already told you that I think an increased use of paraprofessionals, which might include some medical students, but I would not think you could just simply substitute the use of, say, medical students for other kinds of care on a, 1-for-1 or 2-for-1 basis.
a lot of your medical students do a lot of their work at the VA hospitals, and they're not licensed yet, free clinics and things like that. What percentage do you feel that are really major, significant health problems that students avail themselves of your services down there?
Oh, as I say, I think it's a relatively small percent. 10 to 15% of all of the visits might be for something relatively more complicated. But
So the majority is like handing out pills and things like that, counseling. I think a medical student could do that. Very.
If we can get them to, some might be very good at it, and some might be absolutely miserable at it, and think it was beneath them, think it was Mickey Mouse, and the whole bit.
That's why too many medical students are elitist, I think.
Right. Now we're getting at something else there too.
Oh, okay, but if you offer them some money, maybe that that attitude will erode somewhat. Not saying it's
Ken?
going to.
Yeah.
Yeah, an issue that surrounds all these other issues is a feeling of community with the student health center. That, I've never related to it as being my health center. As a student, the walls are white, the desks are put in a position where there's no confrontation.
Oh, it's super, yeah.
It's set up as if
It's
hospital
cold.
administrators
Yes.
have run it rather than having some kind of student input. And it is different from a hospital. It is for students, and you're talking about getting money, trying to provide services for students, and I think students should be involved in that. You're talking about looking for new resources, financial resources, professional resources, and students. There's 30,000 students
Right,
who have
right.
who are more in touch with resources than you can get through your own administration. Yet I haven't felt that students have been involved in changing or growing with student health, or either philosophically or even when you're down there. You don't everything's being run around you rather than with you. You know what I mean?
I would have hoped that this was at least one beginning, or that I agree with you, and I don't see any way to go without involving students as much as possible in some of these decisions.
Yeah, perhaps even
And,
the same money that you're asking, how to utilize student funds. Well, if students made a decision on that, you would get your money immediately.
Right. I couldn't agree with you more.
Okay.
And they can't make a decision until they know what they want and are informed and are making the decision on some rational basis. And
Last time we voted to raise our reg fees for some kind of programs a couple of years ago. The state says, okay, you got all this extra money, this extra dollar for each person, and they cut the state section by an appropriate amount.
yeah, this is another of the little games they play. Yeah. Well, I guess I'm being kicked out, but no, I seriously, and if I sound defensive, I don't mean to be, because maybe I need to be more educated too, and I'm prepared to be, and I really want to talk with anybody that has concerns. Otherwise, I don't know, and maybe you don't. So, thank you for coming. Yeah.